Good evening, class. Today, before we get started on our lecture, I just want to go over a few things just to make sure that we're all on the same page. And let's just look at our syllabus here really quick. So we are on week 3. We'll be starting week 3, and this week you have chapter 20. You can watch lecture and the videos that are posted. Our discussion board is going to be on ACL prevention. So it's going to be an interesting discussion board. I'll probably put something up either today or tomorrow just to maybe get some of the conversation started. Also, you'll have your assignment 3 due as well, lower body sports injuries, and you'll also have your first article review on ACL injuries. Or I'm sorry, the article you have to read is ACL injuries is gender bias. And that is right here. So this article is basically it's kind of like the recap and just the outline of a seminar that took place back in 2006, where um, they gathered, some of the top experts in rehabilitation of ACL injuries. So they took physical therapists, athletic trainers, um, chiropractors, surgeons, and they all kind of met together and just kind of started outlining the current research and the current practices that are in place for ACL rehabilitation, and then also how ACL injuries occur. And just to kind of give you like what the gist of this is about, basically it's going to tell you that females are more apt to sustaining ACL injuries, specifically non-contact injuries. So that's what you have to look forward to in this article. And there's going to be one, two, three, four different questions that have different parts to them. And then at the end here, there's like a little just comment with at the end of this, it says, based on what you know about this, or I'm sorry, it starts talking about the uh, the glute muscle, and it says, based on what you know about this muscle's action and what you have discussed so far, explain a key aspect of ACL injury prevention and rehabilitation, um, and how it focuses on strengthening gluteus maximus. Discuss biomechanics of the hips and knee, and give specific examples of how you would functionally train this muscle. So I know that there's 4 questions here, but I do want you to write this as an essay. Within your essay, you have to answer these questions. So I want you to write it like in paragraph form and everything like that. I don't want you to list each question and then give an answer. I just want you to start just like as if you were writing an essay and a review of this article. And then the last portion is when you can start getting into the rest of this portion right here. This is the very last question. I believe in the syllabus, it doesn't give a specific, um, there's no specific number of pages, but I'm telling you right now, on average, this paper should be at least 2 to 3 pages at minimum. I believe to fully answer all of those questions, you need at least 2 to 3 pages, if not more. Um, so if you're wondering like how many pages it should be, that's about what the average, like what I'm getting, like what I've gotten in my other classes, for really good, well explained article reviews. So just to kind of give you a heads up about that. So you guys, I know it's a really busy week. There's a ton due this week, so just please try to stay on top of this. I'll be available, so if you have any questions on any of this, please make sure that you are communicating with me. If you have any questions, please make sure that you email me, or write something, or start a new thread on the discussion board to ask a question about that. Okay? Okay, so our lecture is going to be on the knee and all the related structures. And the first thing we'll talk about, and I'm not going to go through every single slide. I just want to touch on some of the major points and maybe just give some examples of what these slides are talking about. So the first thing that we'll talk about is the menisci, or we're specifically talking about medial meniscus and lateral meniscus. And as you can see here, if you're actually looking at real meniscus, if you were to just, let's say, cut the knee in half and look down on it, the medial meniscus, so the inside meniscus, the one on your inner knee, looks more like a C-shaped. It doesn't fully close, whereas the lateral meniscus is going to be more O-shaped. And the lateral meniscus is going to be a little bit smaller than the medial meniscus as well. One thing I want you guys to really just remember and make sure that you read this in your book are the vascular zones. So there's going to be 3 different vascular zones, as you can see here in this next slide. And the importance of this is that depending where you get a lesion, or let's say a cut, like when you tear part of your meniscus, the location of it is going to be really important. And the reason is, as you can see here, this red zone, or the outer 1/3 of the meniscus, has the most blood supply. So if you had to choose from, a bad and a worse situation, meaning if you had to choose where you were going to sustain a meniscal tear, this is where you would want the tear, on the outer 1/3, because if there's more blood supply to that area, then that means there's going to be better healing to the area. Whereas this inner 1/3, the white zone, that's where you don't want any lesions, because there's less chance of healing, or there's less, the rate of healing is a lot less in this zone. So like I said, the location of the injury changes the prognosis for our patients, for our athletes. If they have that lesion on the outside, and it's not that large, then they may not need surgery. It may just be 2-3 weeks of rehabilitation, and then they just need that time for the body to pretty much heal itself. Let the body do what it's supposed to. So our meniscus, the medial and lateral meniscus, are there for a couple reasons. One is just shock absorption. So as you all know, the femur, the femoral condyles, they sit right on top of these. So if you don't have these menisci there, your shock absorption is non-existent, basically. So you're basically bone on bone. For those of us that do have meniscus, we're lucky, We can walk, we can jump, we can run with no issues at all. The other thing is stability. This provides a little bit of a kind of like a socket, kind of like in your shoulder, where your glenoid labrum, how it encapsulates the head of the humerus. This pretty much provides that as well, so that the femoral condyles can sit in there a little bit more stable. And then the other thing is just nutrient distribution. There's a lot of nutrients that get distributed through the meniscus as well. So, it's really important to maintain good posture, good conditioning, so that you're not damaging or putting unnecessary stress on these menisci, because you really need them, especially if you're going to be a very active person. Okay, in this slide, we're talking about the ligaments that are within the knee joint: the ACL, the PCL, MCL, LCL. And these are, like it says in the bullet points here, they're named by their distal attachment, specifically the ACL and the PCL, the anterior cruciate ligament and the posterior cruciate ligament. And we'll see in this next slide here. So, for example, right here, the ACL attaches anteriorly in relation to the posterior cruciate ligament, where it attaches posteriorly. And basically that's how they name the ligament. So if you're looking at an anatomy book and it's not labeled, that's how you can tell them apart. Depending where each ligament is attached, you'll know, okay, that's the ACL, and the one that attaches behind it on the tibia is going to be the PCL. So one of the things to note, and we might come back to this later, but the ACL is going to be at most risk when the knee is externally rotated and you have a valgus force striking it or hitting it. So basically, when you have a player that is running and then plants and tries to pivot to, let's say if you're talking about their right knee, they plant their foot and they try to turn to their left. Especially when athletes are wearing cleats and they're on grass. Let's say if their cleat gets stuck, the rest of their knee, so their tibia is not going to rotate with the rest of their body. It's going to stay in that position. So relative to their femur, their tibia is externally rotating, and if their knee collapses, like if it moves inward, that's the valgus force, and that's where the ACL is most vulnerable, and that's how you see most ACL tears as well. So one other important anatomical structure in the knee is the joint capsule. In the knee, it's the largest in the body, and like it says in the bullet point here, it helps form the MCL. So all of our ligaments that we've talked about so far are intracapsular, meaning that they're within that joint capsule. The only one that really isn't is the LCL, the lateral collateral ligament. So with that in mind, we can understand that anytime you have a sprain to one of these ligaments, you're probably also going to have a sprain of the joint capsule. They're pretty much within like especially the MCL, it helps, like it says, it helps form that joint capsule. So it's pretty much like if you were dissecting it, you would have a hard time separating the joint capsule from the MCL because it's pretty much ingrained into it. So there's 4 regions to the joint capsule, and anytime you have an athlete who goes through it and gets an MRI, and the technician, the MRI technician, when they have to write the reports, they're going to describe what part of the joint capsule, what part of the knee that they're talking about in this fashion. Usually they'll orientate the reader by telling them where the lesion is, and they usually will say posterior lateral, posterior medial, anterior lateral, anterior medial. Okay, in our next slide, we talk about the musculature that surrounds the knee. We have all of our knee flexors, our knee extensors, tibial external rotators, and tibial internal rotators, and lateral stabilizers. So if you've gone through an anatomy class, you know that at the knee, you mainly have knee flexors and knee extensors. This portion here, where we talk about tibial external rotation and tibial internal rotation, these aren't really major movements that you're going to be able to see. These are kind of like accessory motions that occur at the knee anytime that we have these specific muscles contracting. So like it says here, biceps femoris helps. It's one of our main knee flexors, but as the knee moves into extension, it also controls tibial external rotation. So this is important to note, because when we get to rehab, if we're doing rehab for, let's say, a patient of ours that has an ACL sprain, let's say it's non-surgical, one of the first things that you're going to start doing is obviously see if you can improve range of motion if they're lacking any. And then the next thing would be to start strengthening. So where do you start strengthening? Well, here's some muscle groups that you would start with: hamstrings, quads, and then also lateral stabilizers. And you want to do this in a progressive way, so you want to start very basic and then move into more dynamic movements. But the reason that you strengthen these is because as the athlete is going to return back to normal activities, you want to make sure that they're stable and that they can rely on their knee and the musculature around the knee to help keep that knee intact and not allow too much medial or lateral movement, or I'm sorry, valgus or varus movement within the knee. One other thing to note, and you'll probably read this in your book, is that when it comes to quadriceps and hamstrings, you need the hamstrings to be at least 60 to 70% as strong as the quadriceps. You can't have a ratio that's less than that, or at least it's not safe to have a ratio that's less than that, because then the quadriceps are overpowering the hamstrings, which means there's not going to be very much limiting how fast or how strong knee extension is produced. And you need that. You need control of knee extension, especially as you're reaching that terminal range of motion. You don't want your knee to extend so fast that you're overstretching all of those ligaments that we talked about earlier, your ACL, your PCL. If nothing's really slowing your leg down as it goes into extension, for example, when a soccer player is kicking a ball, if the hamstrings aren't strong enough to slow down that tibia from extending, you're going to cause some damage, or you're going to be at more risk of spraining or tearing those cruciate ligaments. And in this slide, that's where we kind of explain what I just talked about, that at full extension, the knee can also sustain an ACL tear. So that's why it's important to make sure that the hamstrings are strong enough to control that knee extension. One of the other things to note here is that the second bullet point, the screw home mechanism. Make sure that you read this in your book so that you can get a better idea of how this works. But essentially, as the knee goes into extension, the last 15 degrees or so, the tibia externally rotates. And it does this in order to clear the femoral condyle. And then once it clears that, then the femoral condyles can sit properly over the tibial plateau. So it says the popliteus contracts and externally rotates femur to unlock knee, allowing knee flexion. So in the opposite direction, when you have your knee fully straight and want to get into flexion, this is where the popliteus comes into play. It allows the femoral condyle to clear, and then you can get your knee flexion as well. Okay, so this next slide, it talks about prevention. And what can we really do about knee injuries? Is there anything that we can do to prevent these injuries, specifically non-contact injury, meaning injuries that occur without anyone hitting you or touching you or anything? Because we see this a lot in athletics, and it seems that, or it would seem logical to think, okay, this might be one thing or one aspect of athletics that we might be able to maybe not control, but maybe limit. Maybe we can do something to limit the amount of these injuries where the athlete is just moving on their own and they get injured. So here we have a variety of different things that we can, just double check to see if maybe there's an adjustment we need to make. So the first thing being conditioning. Obviously, if you're working with high-level athletes, this is something that is going to be part of their routine. They're going to have different coaches and people that work with them, getting their body in tune. So they're going to have a strength and conditioning coach. They might have a massage therapist. They might have to do some pre-rehabilitation exercises. They're going to have a lot of things to work on. And that's all just to make sure that they're doing everything possible to really limit the amount of risk that they put themselves in. Again, like I mentioned before, the quad to hamstring ratio, you want to make sure that you don't neglect the hamstrings. A lot of athletes focus on their quads, and then they just totally forget to work on their hamstrings. Gastrocnemius strength, and then also flexibility. Obviously, especially nowadays, most high-level athletes are going to have some sort of warm-up routine where they're doing dynamic stretches, so that there's less chance of, you know, getting a strain or spraining a joint. The other thing is shoe type design. So I think we talked a little bit about cleats, and you know, for the most part now they make shoes they make them really well. So they've, you know, back in the 50s or 60s when they were first designing these shoes, I believe there was a lot of correlation between cleat length and ACL injuries. They would make them too long and then they'd get stuck in the grass. And like I mentioned before, that um, external rotation of the tibia and then the valgus force created a lot of ACL injuries. And then we also have knee braces. In your book, it gives you a variety of pictures and examples of the type of knee braces that they can wear. A lot of college programs require for example, their linemen that they have to wear knee braces regardless if they have a history of knee injuries. Um, and that's not in lieu of, you know, having a prevention program as far as exercise goes. Um, and speaking of that, ACL prevention programs. So um, that's what we're talking about this week. We have we have some prevention programs that have been gaining a lot of attention, a lot of popularity, and as you'll see in the videos that are posted, they have pretty um, convincing evidence or results that, you know, make you think like, okay, this could be a an avenue that a lot of athletic trainers, strength and conditioning coaches maybe need to explore, because it's something that can be easily done. It doesn't take very long. It doesn't take long to do a 15-minute warm-up where you're activating the proper muscles that will help prevent non-contact ACL injuries. So let me go back here. This last bullet point says most common non-contact ACL injuries, the mechanism is tibial external rotation, femoral internal rotation, and hip abduction. So they call this the medial collapse. So this is what it looks like when an athlete is landing, their knee just collapses inward like this. And remember, that's one of that's usually the position that the ACL is most compromised in. So ACL prevention programs, this is what they're trying to work on. They want to improve balance, they want to improve body positioning and gait mechanics, and they want to strengthen the body, but not just by regular strength exercises. They also want to make sure that they're working all these muscles eccentrically, because this is where eccentric muscle contractions come into play when they're landing. When our athletes are landing and they have to absorb that load, that's where we need to train these athletes. We want to make sure that they're used to doing that and they're doing it in the correct manner with the proper technique. So here, for example, is a picture of a before and after. So this is a female that what she looked like after landing from I think this box is about, I don't know, 2 feet or 3 feet. This is what she looks like when she was landing. Before, you can see both knees collapsing medially. Once she went through a injury prevention program or ACL injury prevention program to work on that, this is what she looked like after that. So you can see she has the spacing between her knees, so there's less stress on the MCL and the ACL because she's more neutral right here. In this next slide, we talk about how we assess the knee joint. And this protocol right here, these questions, the type of questions are pretty standard for what you would ask for other body parts as well. You know, as far as history, you ask mechanism, if the person heard anything, did they feel anything, could they move immediately, or were they not able to put weight on their leg? Did swelling occur? Was there any pain? And a lot of these questions get answered or could be answered if you actually saw the injury. But let's say you have an athlete who comes to you and they say, "Oh, I got hurt yesterday. I was playing in a game." These are the type of questions that you want to ask, and that will give you a better idea of um, how the athlete got injured, and then also that helps you narrow down the type of injury down to like maybe one or two different injuries um, before you even start doing any special tests or palpating or anything like that. You can kind of get an idea of like, okay, this sounds like it could be an ACL injury or this could be a MCL injury. Um, that's why it's really important to get a good history when you're dealing with a knee joint. One of the other things you'll do is start observing the athlete, and as you're looking at the athlete, you know, anteriorly and then from behind, posteriorly, and then also laterally. These are the type of things that you're looking for. Genu valgum, meaning that the knees collapse inward naturally, and then genu varum. This is more like bow-legged, so their knees kind of curve outward, and genu recurvatum, which means they naturally have this hyperextension. So when each of these, I mean, everyone might have a form of this, of one of these three, you know, but what you're really doing here is like trying to figure out, okay, this person is probably more predisposed to having an MCL injury because their knee is already in this valgus position. And for example, in genu valgum, the inside here, all these structures are already on stretch. That joint, that part of the joint is already opening up. So everything on the inside would be already somewhat stretched, and then everything on the lateral side would be a little bit more compressed. Genu varum would be the opposite, and genu recurvatum would be, you know, everything posteriorly would be a little bit more stretched already, and that might include the ACL and the PCL, and everything in front here is going to be a little bit more compressed. So once you get to you the special test here, I just want to show you a few of the more common ones. These are the ones that I have to use on a daily basis, you know, when I'm dealing with knee injuries. Anterior drawer test, this is like one of the very first tests that as an athletic training student you learn and you start practicing right away. So here you just, the patient kind of sitting on the practitioner, whether it be athletic trainer or physical therapist, is kind of putting their thigh over the patient's foot just to stabilize, and then they're pulling in the anterior direction here. So depending on their translation, how much translation they have compared to their uninvolved side. So this practitioner here, he's going to have to test the uninvolved side as well, just to compare, like how much laxity they have in there. Next is Lockman's. So here you have the patient supine. So they're not sitting, they don't have their knee fully bent like they did in the anterior drawer. And in this position, you can you can limit a little bit more of how much the athlete guards with his hamstrings. Um, like it says right here, patient may contract hamstrings and prevent translation of the tibia, creating a false negative. So you know, you can do either of these, but or I usually do both. But the Lockman's is usually where I really get a better sense of the translation that I'm feeling. Then you also have valgus stress test. So here you're pushing medially. So you're pushing on the outside, you're pushing medially, and depending on how much the joint space here opens up, that will tell you, and compared to the uninvolved side, that will tell you if there's an MCL sprain. Then the opposite is a varus stress test. So here we're testing the LCL. So same concept as valgus stress test, but the opposite side. McMurray's test is going to be testing for any meniscus lesions. So here you're basically putting the patient in internally rotated or externally rotated, and then you're applying knee flexion, and then also a valgus and varus force. You're basically trying to stress the meniscus in um, every point of it, the outside the inside, and then posterior and anterior. Then we have our apprehension test. And like it says here, most patellas will dislocate laterally. So basically this test is testing the ligaments that hold the patella in place. If there's a lot of translation and the athlete says, "Oh man, that feels like it's going to pop out," that's a positive apprehension result for this test. And you compare that bilaterally. There's going to be some athletes that are very hypermobile. So when you do this, it's going to feel like, okay, that I think I just dislocated their patella, but that's just maybe the way that they naturally are. But someone that has a lot of translation like that, I mean, right away, that's a red flag for me. You're thinking, okay, this person is going to be way more at risk of sustaining a patellar dislocation than someone who has less laxity. Okay, the last slide I want to cover is our knee joint rehabilitation. So these are some of the major parts of our rehabilitation protocol that we want to make sure that we attain, that our athlete regains strength, range of motion, flexibility, neuromuscular control, that they can do everything we want them to do functionally, and we want them to have their cardio back as close to 100% as possible. And we want them to be one, confident that they can go back and do their sport. And part of that is by hitting each of these things, making sure that they're seeing that their strength is going up, that the range of motion is increasing, that they have control of that joint that they've injured that they're trying to rehab. That's going to be one of the more important things to focus on. And another thing is, depending on the severity, all of these phases and all of these parts of knee joint rehabilitation can take different time frames. For example, in ACL surgery, if you're trying to recover from an ACL surgery, it's going to be a minimum of 9 months. That's usually the standard, 9 months, to at least allow that new ACL, if it's a repair or replacement, to heal and to fully be strengthened back to normal. And at 9 months, we might not even be talking about full practice yet. That could mean like limited practice still, trying to get them back into game shape. So if we're dealing with a more severe injury and we're doing rehabilitation for that, you have to still take into account each of these parts. You're not going to bypass anything. The athlete is going to might be motivated to get back on the court, on the field as soon as possible. They want to skip some steps. It's your job as a clinician to make sure that you're documenting their progression, that you're documenting how well they're improving, and you show them that, and you tell them, listen, you're doing a great job doing rehab, but you're not there yet. You're not fully there yet. We have to allow the body to do what it's supposed to do. We have to give it enough time for it to heal. We can't rush that part of it. There's obviously a lot of supplements and things that athletes can take that are out there on the market, but there's not a special pill that will help you get back on the court or on the field any faster than the time that it takes for tissue to heal. So just something to keep in mind. So that's going to be the end of our lecture there. But if you have any questions regarding any specifics, like if you want to know anything about ACL injuries, MCL injuries, anything like that, you can start a thread on the discussion board or just shoot me an email if you have any more questions about this or about any of the assignments for this week. Thanks and have a good night.